Welcome to the Behavior Speak podcast. Now, here's your host, Ben Ryman.
Welcome to another episode of the Behavior Speak podcast. As always, I'm your host, Ben Ryman. Excited about today's episode. Today, I always like when I'm able to have a conversation with somebody who's using our science in areas that not a lot of folks are, and so we've seen lots of good research coming out in, things like OBM and safety and just did a recent interview with Wes Lowry on sports behavior analysis, and so there's really lots of cool areas where we can apply our sciences well beyond sort of the autism world, and so I think it's really good for folks to learn about these areas and potentially if they want to kind of go in them themselves, but also just to know that there are they may come across clients they're supporting that have some issues that go beyond sort of the typical types of challenges we might be used to, and so it's always nice to get a different perspective. And so today I'm very happy to have Shrinidhi Subramaniam of University of California, and she's
California State University.
Thank you, and she's going to pronounce the full word of Stan State for me because I never get it right. What's the Stan?
Stanislaus.
Stanislaus. Thank you. I can never get that right. Well, Shrinidhi, thanks so much for being on the show.
Yeah, thanks for asking me to come talk.
Amazing. I always like to kind of get a little bit of an origin story on folks, kind of how they kind of got into the field. I think it's nice to kind of get background, but I think it also helps younger folks and students who may be wondering kind of how they get from point A to point B, to get a little sort of timeline from folks, because often folks enter the ABA field in sort of a similar kind of way, but then to eventually kind of get over to a more unique specialization, I think folks really can find that information valuable. So maybe you could just tell us a bit kind of how you got into ABA in the first place, sort of just your beginnings there, and then kind of what brought you from maybe a sort of a standard, more maybe autism focused intervention sort of realm into sort of into kind of more into substance addiction and poverty.
For sure. That's a great question. I got into ABA through the experimental analysis of behavior, so I might be kind of a unicorn in the field in that way. I went to undergraduate at Armstrong Atlantic State University. Now it's a campus of Georgia Southern University. At the time, it was Armstrong Atlantic State University, and there was a behavior analyst over there, Dr. Forrest Files, and he was working on alcohol self-administration studies with rats. Now, when I started at Armstrong, I was mostly interested in addiction, and that's always been broadly a research interest of mine. I don't know anyone in this world whose life hasn't been touched by addiction in some way. And so one of the things that I wanted to do with my career in psychology is investigate the conditions under which people become addicted and how we can treat this kind of disorder. And when I went to Armstrong, I heard Dr. Files was working on research related to addiction. And I got up the nerve to ask him if I could be a research assistant in his lab. It was a really nice teaching type university, just undergraduate students in the psychology department. And so Dr. Files was excited to welcome me to the lab, but he wanted to make sure that I understood what he was doing. He said, I do research with rats, right? Which intrigued me because he applied the basic science of the experimental analysis of behavior to look at drug use as operant behavior. And so I got involved in that lab, mixing up sugar solutions, getting rats to drink, finding out, what is the right ratio of sugar to alcohol to get them to start to self-administer, because rats are not just going to drink grain alcohol. I'm sure most humans don't start drinking with grain alcohol. They start drinking with mixers and sweet beverages that are mixed with alcohol. And that started my journey in behavior analysis. later on, Dr. Mirari Alcoro joined the faculty at Armstrong, and I started working with her on setting up the rat lab that she ended up setting up. And she was a graduate of West Virginia University. And so she began to talk to me a bit about her experience there. And I thought it sounded like a great school. And so I applied to go there for my Ph.D. program. And I got in and I started working on investigations of basic behavioral processes like choice and timing that sort of underlie addictive processes with Dr. Elizabeth Kayonka, who ended up being my PhD advisor. And so I say I got tricked into ABA because really my journey started with EAB. But when I was at WVU, West Virginia University, I got a research assistantship with Dr. Claire St. Peter, who was doing some work on training parents of children with autism to implement discrete trial training in the home setting. And she was interested in disseminating that intervention through telehealth kind of resources and really old school telehealth, like mailing these parents videos of how to do DTT through the postal mail, or mailing them written instructions on how to do DTT through postal mail. And so I got the experience of, practicing applied behavior analysis in that way, in that parent training, telehealth kind of way. And I continued to work with Dr. St. Peter throughout my graduate school career there at West Virginia. Ended up getting the hours to sit for the BCBA exam and took the coursework and became board certified.
Okay, wow. So you, joking, of course, but you totally went against my entire theory of how you got into the field. So yeah, you kind of went the whole opposite route. Like again, most of the guests I've had on here started, as maybe an RBT or some version of that earlier before that name existed. Went to college, saw an ad on the board, did some home programs, got into the field that way, and that's sort of been their journey. And then anyone who sort of specialized, it was way down the road. But your experience is kind of the opposite. You were sort of introduced to you already had an interest in addictions kind of coming into the program, and so this was something that was sort of mind, like even before you started your undergrad. Was that what it was, or
when I was an undergraduate student?
And was it, and without sort of getting too personal, was it sort of from life experience of knowing folks who were addicted and wanting to learn more there, or was it just sort of something in the undergrad program that just sort of spiked your interest?
Yes, for sure. I have known people with addiction growing up, and I experienced my own experimentation with alcohol and drugs, and it was just fascinating to me to get a better understanding of those mechanisms scientifically, because it is so intriguing from a lay person's perspective. And we come up with all kinds of strange and inventive theories about why people use drugs and why they continue to use despite negative consequences, but generally don't understand the principles of effective treatment that we've learned through science. And so I have a scientific background. I've always kind of thought like a scientist. And so I wanted to use my psychology career to get a better understanding of addictions from that perspective.
Oh, that's really cool. We kind of had a bit of a chat a couple of weeks ago and kind of dove into your research a bit, but one area we kind of didn't really talk too much about, and I just wouldn't mind getting a little bit more sort of detail, only because I just recently did an interview with another fella, Val Saney, who also was doing a lot of EAB stuff. And I have, prior to him, I had not interviewed anyone who was doing EAB, and nor did I have any experience doing EAB, or nor did even my graduate program even touch on really EAB. If my supervisor listening and you did touch on it and I missed it, I apologize, but I don't think we did. And so he kind of really went through a lot around translational research and that whole
Hmm.
piece, and kind of explained that whole process to me, and made it quite a bit more interesting to me. So I'm curious, sort of as it relates to, I guess, to maybe more the alcohol drug piece, those areas of sort of choice and timing, and what was the other one? Was it impulse? Or
Hmm.
so what are you looking at with when you're looking at kind of those areas, and kind of how does that relate to drug addiction?
That's a big question, and I can touch on it a little bit. I think
Yeah.
everything we do can be drilled down to these sort of basic behavioral processes,
Mm.
and of course, the more complex we get, addiction is a pretty complex process that involves neurobiological mechanisms, but also behavioral mechanisms and the choices that we make. And a lot of times people talk about, there's this controversy about addiction as a choice
Mm.
versus a compulsion. And I think the real debate there is on how we view choice. Right. And behavior analysis has done a lot of great work for many, many decades on conceptualizing choice as the allocation of behavior, right? The allocation of behavior to different alternatives. And so when we think about using drug use as an operant behavior, it's a behavior that's maintained by its consequences, but it's also a behavior that occurs when other concurrently available options are there.
So we had a little bleep there, but we were talking about kind of in terms of sort of the EAB perspective, and how there's kind of some of these sort of basic, the constructs, I guess, choice and timing, and some other things I think you were starting to say, um, kind of apply to a whole bunch of different areas. Maybe just a little bit. We won't dive too deep into the EAB realm here. I know it's a bit of a broad question, but
Okay.
kind of how studying that stuff can help, with understanding sort of addictions and things like that. If you're planning on collecting continuing education credits for this episode, you'll need to go to cbiconsultants.com and enter the 3 secret words. The first secret word is addiction.
Yeah, I think one way that it helps is to get this idea of addiction as operant behavior that's maintained and modifiable by its consequences. So if we think about drug use as an operant behavior, we can identify some functional relations between the environment and that behavior that can be used to get a sense of why this behavior is occurring and how we can address the behavior. And there's a lot of basic research, EAB, on quantitative models that describe and help us to understand operant behavior in general. And that's things like the matching law and conceptualizations of impulsivity as delayed discounting, which some have even proposed is an underlying behavioral mechanism for all addiction processes. And so getting an understanding of, just looking at drug addiction as an operant behavior helps me to take that behavior analytic perspective and apply it to the potential for treatments and the general understanding of addiction processes. One of the things that I find interesting when we talk about addiction and conceptualizing addiction is some people say that addiction is a compulsion and other people say addiction is a choice. But I think it all boils down to how we define choice. And behavior analysis has given us this values-free conceptualization of choice as the allocation of behavior across alternatives. And so if I can look at drug use as a choice that's simply the allocation of behavior across alternatives, then the important question is, what are the alternatives? And drugs are powerful reinforcers. And what are some ways that you can shift choices away from powerful reinforcers? Well, you can offer other powerful reinforcers, which kind of led me into my interest in the more applied work in contingency management.
Interesting. Yeah, because it's interesting that your point there about sort of, whether it's a compulsion or a choice. I was talking to someone about Now, and this may not sort of fit the same realm. I don't know if it does. I mean, when we talk about addiction, and again, I'm certainly by no means an expert in this in any way, but when we talk about addiction, we think about drugs and we think about things with chemicals, and that we ingest or inhale or whatnot, that then have some sort of effect on our brain, and then sort of the assumption there is that effect on our brain creates this kind of compulsion, as you put it. But then when we start thinking about sort of other addictions, like gambling or food, although that's still putting something in your body, or sex addiction, I guess, is another one that they talk about, where there's no sort of substance going into your body. And then, and when I've talked to other behavior analysts, they've actually suggested, particularly in terms of sex addiction, that that's not a real thing. Sex addiction is not a real thing. The psychologists say it. The DSM says it. It's not a real thing. Like, what do you do with that? Like, I as far as sort of, I hear what you're saying about it sort of being, operant behavior, but then there's sort of the chemical side of things that's sort of affecting things. Is it just that the chemicals are the powerful reinforcer and that's it? We just got to find something better, also deal with the withdrawal symptoms and whatnot of sort of being on that chemical. I don't even really know what my question here is now. I kind of come to babbling here, but I guess part one is sort of, what makes it an addiction, and part two, does things like gambling and sex and these other sorts of addictions, I guess, that don't involve ingesting something, do they work the same way as far as when you're coming at it from that sort of EAB perspective?
Sure, yeah. So in some ways they do work the same way, and in other ways they don't. And you're right, the distinction between interoceptive stimuli, those internal chemical changes that happen when someone ingests a drug, the occupation of receptors and that kind of thing, is going to be maybe different than exteroceptive stimuli. For example, a gambler looking at a slot machine with those 3 cherries on the pay line. But I can't speak to the total body of research comparing behavioral addictions to substance use disorder and why some behavioral addictions are diagnosable. So gambling disorder is diagnosable, binge eating disorder is diagnosable, but not sex addiction or smartphone addiction. That's been something I've been trying to learn a little bit more about recently, is this just need to have that smartphone. And there are similar symptoms with behavioral addictions that involve sort of more compulsive behaviors and exposure to exteroceptive stimuli that are very similar to the symptoms of substance use disorder. People have experienced or reported experiencing withdrawal when they can't have their smartphone, that they get irritable and uncomfortable when maybe they leave their smartphone at home. People have developed tolerance to gambling, and these other kind of traditionally physiological ideas of dependence that we have for substance use disorder. So, and others have done really interesting research showing that the neurobiology underlying substance use disorder and compulsive overeating, for example, it's really similar. Like the same brain pathways are activated and the same biological processes are happening. And so there are arguments that these are not things, and there are arguments that all addiction has the same underlying processes. But it's a big question that has yet to be answered, is what makes an addiction an addiction. I think the clinical answer would be clinically significant impairment or distress. And so, if somebody says that this is a problem for them, then we should assume that, okay, this is a socially significant problem for them. And they should have access to the kinds of treatments that can solve that problem.
Totally. Yeah. No. And I'd be interested to see kind of if you end up actually doing some research in the smartphone realm. I was thinking sort of, and this will date the recording of this episode, but the the shutdown, as it were, of the Facebook, Instagram there last week, where for what is it, for 6 or 8 hours people couldn't access those things. And I know even myself, I was engaging in kind of maybe some withdrawal like behaviors as I was clicking on it over and over again and trying to make it happen and getting frustrated that it's not happening, and then realizing, wait a second, I'm getting a free break from this stuff. Why am I so stressed that for 6 hours I can't look at my phone and sort of access some of these websites? So I imagine all of the world was going through a sort of temporary withdrawal experience there.
Mm-hmm. And this idea of craving too. So taking you back to that EAB realm, I did a really simple experiment when I was an undergraduate at Armstrong. Is I looked at craving as an increase in response rate following a period of abstinence. And we can call craving, of our smartphone or our internet or our, a lot of people have cyberspace oriented relationships is one of the underlying addiction processes with smartphones and internet, is that we want to have that social connection that we have. And so that increase in those clicks trying to log in, we could just look at that as operant behavior.
Yeah, totally. Really. And so just one other kind of question on the EAB thing, because it's so fascinating, and maybe another time we'll just talk about that. But when we're kind of understanding addiction, does EAB kind of have an explanation for the addiction while you're the addiction piece, or maybe I don't know if that's the right term, but sort of the behaviors you engage in when you're consuming the substance, so your brain's actively receiving those drugs and whatnot, versus the behaviors you engage in when you've gone through a long enough period of abstinence to not have the chemicals in your system anymore.
But yet you're
still, yeah,
and some would call this more applied research, but there's a large body of research on behavioral pharmacology looking at stimulus discrimination and drug discrimination and self-administration under different conditions of intoxication versus abstinence. And you can model those same functional relations at different doses of drug, and get an idea of an individual's ability to learn, or to time different stimuli that are presented to them, or to make self-controlled choices, or choices for the larger later versus smaller sooner reinforcer. And there's a great body of research on it spanning several decades. In the 1960s, there are some amazing studies on drug self-administration.
Okay, wow. So behavioral pharmacology is a whole other realm that one can kind of enter if they want to learn more about that piece. Very good.
Yeah.
Okay, well let's maybe start diving into some of the work you're doing right now. So you've been or you've done sort of over the last I guess 5 or 6 years now, even or longer. You and a group of folks have put out a bunch of research, kind of all seeming to be kind of a similar project related to this sort of idea of the therapeutic workplace, which I think which we can dive into a little more and get an idea of what it was. But kind of how did you kind of, because and we're going to dive into this here. I kind of just don't even understand how you do this kind of research. I mean, these subjects are a totally different breed. There's in terms of sort of motivation to want to participate, and and sort of all those pieces. So maybe just talk a little bit first about kind of what this whole research project has been about. You've put out quite a few studies on kind of some different areas, but I think they've all kind of been around the same kind of context and maybe some of the same subjects. So kind of what was the aim of the whole project? Who's involved? Kind of that bit of that overview, and then before we kind of dive into some of the components.
Yeah, so after I graduated from West Virginia University, I landed my dream postdoc position at Johns Hopkins School of Medicine in their Behavioral Pharmacology Research Unit. And I got to work with Dr. Ken Silverman, who developed the therapeutic workplace. He's a great researcher who's been doing this work for several decades, and most recently with Dr. August Holton, who's working with him on modifying the therapeutic workplace or building on the therapeutic workplace to support employment outcomes in individuals living in poverty. So when I got started working with them, I was interested in addiction. I'm definitely also interested in poverty. I am on board with this idea that we have a hierarchy of needs. And if our basic needs are met, then it's less likely that we'll engage in aberrant behavior. And so a lot of people who are using substances are perhaps pulled to the use of substances because other aspects of their life are not reinforcing. And especially in the United States, this is capitalist society where I live, having money, having income, and having satisfying employment definitely helps people, make those choices that are ultimately beneficial in the long run. And so a lot of people who are living in poverty who will also engage in chronic drug use might not be engaging in drug use if they are pulled out of poverty, if they have access to financial resources, access to employment, and a way to live a more satisfying life. And so the participants who they work with in the therapeutic workplace have typically been characterized by the medical community, by the psychology community as treatment resistant. They're individuals who are have experienced treatment episodes for substance use disorder, but have not maintained drug abstinence or maintained good treatment outcomes following treatment. So they might have been people who have been in this revolving door into residential facilities. And the way that Medicaid and other reimbursement systems work is that people can only have so many treatment episodes. In general, people can only have so many treatment episodes in that intensive placement. So in a residential treatment. And so they're going into residential treatment and coming out and then relapsing to drug use, and then coming back in and maybe, having bouts of outpatient treatment. Maybe they're in medication-assisted treatment programs like methadone and buprenorphine programs. These are medications that are FDA approved to treat opioid use disorder. So individuals can be maintained on those medications for a long time, and it generally helps people to stay abstinent. But then there are certain people who are in methadone programs who are also addicted to cocaine, which has no FDA approved pharmacological treatment. And they're on methadone and using cocaine at the same time. And that leads to a lot of distress in their lives. And so in the 90s, Steve Higgins developed a voucher-based contingency management program for individuals with who were addicted to cocaine because there was no specific pharmacological treatment for them, and other general psychology-based approaches were not working for most people, at least for those treatment-resistant people who were using cocaine and methadone treatment or continued to use cocaine despite being able to quit other substances. And so the intervention was just a positive reinforcement-based intervention where individuals submitted urine samples. The urine samples were tested for metabolites of cocaine, and they could earn vouchers for drug-free urine samples. And importantly, he developed this escalating schedule of reinforcement where initially participants could earn some small amount of money, and then with each consecutive cocaine-free urine sample, they could earn a little bit more and more and more until they got to the highest value. And that escalating schedule tends to sustain longer periods of drug abstinence. And they found this program to be quite effective for people with cocaine addiction. And there have been a lot of different applications of contingency management since. Since then, contingency management has been recognized as an evidence-based treatment for stimulant use disorder, for addiction in general. It's been applied to a variety of different populations in a variety of different ways, using different reinforcers like prize-based contingency management, where the reinforcer is not a monetary voucher, but a good or service that the participant got as a prize. There has been employment-based abstinence reinforcement, and that's been pioneered by Dr. Silverman in the therapeutic workplace, where individuals could earn vouchers or monetary incentives. Now they're doing them on reloadable credit cards for drug-free urines, but also for work. So they attend a workplace and they can earn their incentives as wages, and they can earn maximum incentives for drug-free urine samples, in addition to showing up and participating in the work. And the work is usually some sort of therapeutic work, targeting behaviors that are socially significant for the participants. So things like job skills training and education. So they come in, they do work. The work is job skills training and education. They earn wages for the work, and they can earn maximum wages for maintaining drug abstinence as well. And so when I started working with Dr. Silverman and Dr. Holton, they were conducting a large-scale evaluation of the therapeutic workplace using a wage supplement model. So any time you have a treatment for addiction, whether it be methadone, cognitive behavioral therapy, or contingency management, when the intervention ends, usually a lot of people will relapse. That's the case across the board with any sort of treatment for addiction. And that's definitely an issue that's been brought up in the research on contingency management. When the incentives end, many people will relapse to drug use. And so one of the solutions to that is to maintain the contingencies for a longer period of time to see if you can maintain abstinence for a year, 2 years, 3 years, or 4 years. After that, will the person be so used to drug abstinence and a drug-free lifestyle and engaging in alternative behaviors that then when the incentives end or are faded out, they're able to continue with drug abstinence? Dr. Silverman, in some of his research, has extended the therapeutic workplace, I think up to 4 years, and they found that wow. And they found that after 4 years, they didn't see any difference between groups in their abstinence outcomes, but people continued to participate in the treatment. So when we think about treatment-resistant participants, they're not so resistant to contingency management type interventions because of the rich schedule of reinforcement that they get from participating in those interventions. So the study that I helped complete was a study of a wage supplement model to maintain abstinence contingencies over the long term, and also to promote employment in real jobs in the community. So you can keep the incentives indefinitely, but you can also try and get people to access a higher income, access more resources from their community through the treatment. And hopefully by doing that, getting people employment, they'll be able to continue being drug-free for a longer term. So in the therapeutic workplace, there are 2 phases. The first phase is usually takes place over about 3 months, and it's an abstinence initiation and training phase, where individuals will experience those abstinence contingencies to earn their incentives, and they'll participate in the job skills training program. And then in phase 2, that's where you can test some different ways to extend the contingencies or help people to access other reinforcers in their life. And the model that we evaluated was the wage supplement model. wage supplements have been used by governments and other nonprofits to help individuals who are living in poverty to gain and maintain employment. And what wage supplements are just additional monetary incentives for getting a job and keeping a job. So what we did was we offered participants wage supplements for getting employment in real jobs, competitive employment in the community. They would hand in in phase 2, which lasted a year, if they were able to get a job right away, they would continue to drug test with us. We faded the frequency of drug testing for individuals who had sustained abstinence so that they wouldn't have to test 3 times a week, which is kind of difficult to do when you're out and employed.
Sure.
But we would fade out the frequency of drug tests, but we would offer them wage supplements for the hours that they worked, verified by their official pay stubs from their employers. Participants could earn their pay and could earn up to an additional $8 in incentives for every hour that they worked up to 40 hours a week. So they could earn thousands of dollars in wage supplements for getting a job and maintaining that job over and above their paychecks. And we thought this might be a really good way to encourage employment. And we thought it might also be a good way to help people get out of poverty too. So we evaluated the incentive system, the wage supplement system, in a few different papers that we've published since. And in the main trial, we found that yes, the wage supplements were helpful in maintaining long-term drug abstinence and also in promoting employment. And interestingly, the wage supplements were effective in helping people to get out of poverty. And so how we looked at this is we compared whether or not people in each group. So we did, this is a randomized control trial. So there were 2 groups and it was a between subjects design. So we compared a usual care control group who were people who were invited to work with a job employment counselor and continue to come to the therapeutic workplace after phase 1, but they did not earn the wage supplements. And participants in the wage supplement group were able to work with the employment counselor and also earned wage supplements. And what we found was that a higher percentage of individuals in the wage supplement group were out of poverty by the end of the intervention and in each month of the intervention than individuals in the usual care control group. And this was not counting, so it was just looking at their wages, not counting the wage supplements that they earned. So even when we subtracted the wage supplements out of their overall income, individuals in the wage supplement group were able to get out of poverty at a higher rate than individuals in the usual care control group.
Okay, lots of stuff there. So
yes.
Really cool. So with I'm confused by the wage supplement. So the wage supplement is in addition to sort of what they're already making at this job. And this job is within that therapeutic workplace?
That's a good question. So in phase 1, their job was within the therapeutic workplace. Once they were in phase 2, they were invited to work with an employment counselor who would help them to find jobs, put in applications, do mock interviews, build their resumes, help them to get employment as rapidly as possible. And some participants got jobs right away. And other participants took a little while to get it. Actually, we had one participant who was in phase 2 for 50 weeks before they were able to get a job. But those last couple of weeks, they got a job and they got some wage supplements. And other participants took a slower approach where they joined training programs to get more specialized jobs. And once they got those specialized jobs, they were able to earn their wage supplements. Participants could still earn incentives for working with the employment counselor, but they could earn incentives only for up to 20 hours a week working with the employment counselor. So the real incentive was to get a job. That way they earned a paycheck, and on top of that, they earned wage supplements.
I see. So I was trying to imagine how one would fund both the wage and the supplement at the same time. That's
right.
The thousands of dollars, as it were, all coming out of your pocket could be tough to sustain. So that makes a lot of sense. So now, in terms of kind of I want to go back to the contingency management in a minute, but in terms of sort of the sort of longer term effectiveness. So did some of these wage supplements over time get faded out?
Yes, so at the end of the intervention, we didn't have a fading procedure for the wage supplements. At the end of the 1 year of phase 2, the participants just stopped earning the wage supplements.
Okay.
And the data for the follow-up with them is forthcoming. So we'll have something interesting to say about that maybe later on.
Excellent. Yeah, that'll be really interesting to know sort of what kind of some of those long-term outcomes are, because your point before about sort of contingency management working really well, but then once you stop it, everyone kind of relapses, and so it makes a lot of sense to sort of let's create a system where they can actually get their own jobs, so they're continuing to have income, and I won't make you give away the cliffhanger, but fingers crossed that some of these folks were able to sort of keep things going.
Yes,
after.
Yes, and I think even during, there were so many benefits of just being able to earn those incentives, have a little cash in their pockets. A lot of times people who are in drug addiction treatment or have chronic histories of drug use also have legal problems because of the criminalization of drugs and possession of drugs that we have in the United States. And they might have some physical problems associated with their drug use. A lot of people in methadone treatment tend to gain a lot of weight. People who use certain drugs have dental problems, and just having a little bit of money and having that job training and people who have, I don't know, are encouraging these individuals to try and get a job and supporting them in that process can be really helpful, builds up their, feelings of self-efficacy, but it also gives them resources to clean themselves up. And one of the things we did was the employment counselor worked with participants to look a little bit better for their job interviews, because that can be, a first impression means a lot. But in addition, one of the participants in phase 1 showed up one day and just looked at me and had this glowing smile on their face. And when I looked at them, I noticed they had a whole new set of teeth. Oh. And they were able to afford those teeth just because they enrolled in our study and were able to earn some incentives and have, money to spend on taking care of themselves. And that's an investment that will last that person the rest of their life. Hopefully they had a good dental surgeon who put some good implants in. And so, yeah. So there are a lot of benefits of just giving people resources. I think people living in poverty, if their basic needs are met, it's going to help set them up for success long term.
The second secret word is generalist. Totally. There's an assumption I think that some folks still have, though, that if you give someone who's addicted to substances money, that they're just going to spend it on substances, or spend it more on sort of other sort of nefarious activities. But you're saying that's generally not the case. That if folks have access to some resources, they're more likely to actually try to sort of help themselves out.
Yeah, and I think the key thing about abstinence reinforcement interventions is that they're only going to earn the money if they're continuing to be drug abstinent.
Oh, of course, right.
And so there are other applications of contingency management, like paying individuals to adhere to their medications, or paying them to attend therapy sessions. But usually people, if they relapse into drug use, usually they will also stop taking their medications and also stop attending therapy sessions. So usually that drug use is correlated with the outcome that is not where the reinforcer is withheld. So yes, people have that concern, but in contingency management, that's generally addressed by the design of the intervention, where the reinforcer is withheld for when the target behavior is not emitted.
Yeah, no, that makes a lot of sense. Absolutely, yeah. I had no idea that contingency management had been in terms for sort of drug use has been around for so long to the point that it's reached sort of that status of an evidence-based practice. It doesn't seem is that a well, I guess maybe number one, is that maybe just an American thing, or is that just something? Does it sort of like, is that something? Are we seeing a lot of contingency management programs in just regular sort of drug rehabilitation programs?
That's a great question. And, it might, at least in the United States, it's been recognized for some time as an evidence-based practice through the National Institute of Drug Abuse. It's been recognized as an effective program by the White House in 2014. The Therapeutic Workplace was recognized as an effective program for the treatment of drug use by the White House. I think what researchers and clinicians have been trying to do, at least in the last couple of decades, is look at how we can disseminate contingency management in a practical way. Like you mentioned, that it gets expensive, especially if you're paying someone's wages, you're paying their wage supplements, you're paying their incentives for drug abstinence. And the research has been supported usually by large grants that come from National Institute of Drug Abuse and other like substance abuse mental health services. So there have been efforts by researchers to try and make this a more mainstream practice, but by no means is contingency management as mainstream as I'm biased, but as I think it should be. And so I appreciate those efforts. So Nancy Petrie was a pioneer researcher in disseminating contingency management and conducted a lot of research evaluations on what makes contingency management appealing to practitioners, how to disseminate the intervention. For example, in the Veterans Administration, 2011, she published a paper on contingency management applied on a very large scale in the United States Veterans Administration. And that program was funded by money allocated by the VA. And so they were evaluating contingency management programs to help veterans with substance use disorder to adhere to their substance use disorder treatment and to stay drug abstinent. There are also a number of other demonstration projects happening now. I think some are funded by large departments allocating money toward the treatment of substance use disorder with this evidence-based practice. Others are funded by insurance companies. I think the one limit to that is that there's some law, and I'm no expert on this law, but there are anti-kickback laws where insurance companies cannot provide money to providers in that form that they can then give to clients as incentives. And so there's been some fight against this legislation. At least to pause it when it relates to contingency management, because it is so effective. But there are some demonstration projects that are happening in different cities where they're evaluating smartphone delivered contingency management that is funded through private partnerships through insurance companies and other businesses that are trying to disseminate contingency management. And so really we're going to see a lot of that work coming out in the next decade.
That's really cool, because that kind of my next question was going to be, but I'm going to change it a bit here. We're just going to be sort of, where do you get the money and to sort of pay for all this beyond grants, and how do you sort of convince folks that beyond grants that spending this kind of money up front could be a good thing. But I think what you're saying, and correct me if I'm wrong, is that there's these insurance companies, which and we don't use the insurance model in Canada. We sort of use that model for billing, but it sounds like what's happening is the insurance company would normally have to pay for if the individual had insurance, that is, would normally have to pay for the expensive rehabs and the residential treatment, which I imagine is probably way more expensive than any kind of outpatient contingency management kind of program. And so is what you're saying is that the insurance companies are actually seeing the possible benefit of putting money into contingency management because in the long run it might save them money?
Yes, I think so. And one of the smart things that researchers are doing in their clinical trials that are funded by large grants is that they're also asking health economists to participate in these trials as evaluators, as collaborators. And the health economists are characterizing the cost benefit of this kind of treatment, like in the long run. So, are we avoiding emergency room visits, which are very expensive?
Yes.
Are we avoiding other treatments that would otherwise be put in place and paid for through those companies? And to what extent, like how much is contingency management reducing those other healthcare costs because of its effectiveness in right now? And so, yes, there's good research on the cost benefit that's been done by partnerships between behavior analysts and health economists in these large research projects.
Oh, it's just mind blowing, and I say it. I mean, I think sort of as a a bit of a sort of leftist thinking individual that I am. I often think about sort of, and also just being kind of working in kind of the PBS realm a lot. I often think about sort of how much can be saved in sort of every kind of sector. And I know a lot of people think about this as if we put more money into prevention,
Right.
more upfront money into prevention prevents the long term, you know, extreme expenses. I mean, a common example, sort of in the kind of intellectual disability field, is if we put the right kind of interventions in for children, especially those who might have more kind of severe challenges, we might be able to avoid things like group homes, which are just ridiculously expensive to run. I remember supporting an individual who, and just for comparison's sake, young children we're digressing in the topic here, but young children in my province, under 6, get something like $20,000 a year for autism services. But but adults who are like over 19 who end up maybe have autism or whatever, and really severe challenges, living in a group home, can end up being funded as high as $200,000 a year to live in that residence. And so it's a ridiculous amount of money that's sort of spent to sort of keep these individuals safe and healthy. And so so just one example of many out there of how programs like the ones you're describing can really lead to long-term savings. And I think we've always known that or had that thought, but the idea that these big insurance companies have actually grabbed onto this idea is so promising, I think, for other areas too that maybe have done levels of kind of prevention research and whatnot. Like it seems like this is a concept that I would not have thought would have existed 10 years ago. That the essentially the and I'm not to sort of characterize all insurance companies as capitalist money-making organizations, but some of them are. And so to sort of
Generous.
maybe all of them are, to sort of I have no idea, but to sort of see that, because I've always thought if we could find a way to make the guys with the wallets feel like their wallet could get fatter by doing this, then we're set. We've got an intervention that we can now fund for the rest of our lives. And it just seems like you're the first example I've heard of that actually may be happening.
Well, I think that's real. So you brought up a lot of interesting points, and I think prevention is so important. And when people think about addiction, they don't think about classroom interventions as prevention. But in the 1980s, a researcher by the name of Kellum was conducting large-scale evaluations of the good behavior game. This is an applied behavior analysis intervention, right, that has expectations and rewards in the classroom, and that's implemented by teachers and has shown to decrease problem behavior and increase desirable academic behavior in the classroom, or at least enable students to meet their academic goals because of the decrease in problem behavior and disruptive behavior in the classroom. Well, Callum conducted an evaluation in Baltimore, Maryland, in several different public schools of the good behavior game in the first grade classroom specifically. First grade, it seems to be such an important developmental time where a lot of different things, a lot of different interventions have been shown to prevent negative outcomes in the future. But with the good behavior game, they found that good students in good behavior game classrooms versus students in the regular classrooms or traditional classrooms were less likely to engage in problematic substance use. They were less likely to engage in risky sexual behavior. They were less likely to be considered aggressive, for boys at least. I don't know how much that has to do with other structural problems in the labeling of aggression in boys, but the good behavior game classroom, the good behavior game was associated with reductions in the risk of substance use and in the risk of risky sexual behavior. And I thought that was so interesting to think about, right? Like just these behavioral interventions at this critical period of time can have really large downstream consequences later on in an individual's life.
That's really cool. The studies you put out several here, and I think you got probably a couple more still coming out. You talked a lot about this kind of wage supplement model, but they also talked about a couple of other possible models that could be used, or that I think maybe Dr. Silverman might have looked at as well. Can you touch on those a little bit? That there's some other ways of looking at this?
Yes, there are a variety of different approaches to take in phase 2. Phase 1 of the therapeutic workplace is traditionally, again, it's that abstinence initiation and helping people to build their skills in those first 3 months of abstinence. In phase 2, you can try a number of different approaches to maintain the intervention long term. One approach that has been evaluated in the early 2000s, some of this work was being done, was a social business model. A social business is a business that runs like a business, right? They hope to get profits, but the profits are not going into anybody's pocket in particular, but rather going back into the social business to help the individuals who are employed in that business. And so a social business model of the therapeutic workplace looks a lot like in phase 2, the participants are doing a job and they're earning money for doing that job. And any profits that are made are used to hire more people to do that job and to continue to keep people employed. The researcher who developed this idea of social business has actually won the Nobel Peace Prize. And this is Muhammad Yunus. And the goal of any social business is to solve a social problem. And we can also think about social firms in a similar way. These are businesses that offer employment opportunities to people with mental illness or differing abilities.
Yes.
So we're seeing a lot of those pop up, and they're doing a lot of good work for the employees and for their communities. So the social business model of the therapeutic workplace employed individuals after phase 1 into data entry services jobs. And so they learned keypad and typing skills in phase 1. And the people who learned those skills really well, they actually use fluency-based programs and pretty much 1-minute timings, precision teaching type programs to teach people to type and do keypad entry. People who ended up learning skills and initiating and maintaining abstinence in that phase were then hired into the social business where they used those skills to enter data. They sold those data. They got money for the business, which then went back into it.
That's awesome. I love how you're able to sneak a little PT into there too for teaching those skills. That's so great.
Well, Ken Silverman worked with Ogden Lindsley.
Oh, well, there you go.
Yes. So he does a lot of great fluency-based instruction in phase 1 in the therapeutic workplace. Some of the projects that I got to work on were looking at individuals' reading skills and computer-based treatment for reading. And actually, we started to build some computer-based training for helping people with broader digital literacy, because in the 21st century job search, you got to be able to fill out job applications online. And if you don't know how to enter text into a form, then you're not going to be competitive for employment in the community. So there are a lot of interesting potential thesis projects for students and projects for building computer-based training that are out there for applied behavior analysts to get involved with.
Kind of a tangent, but just because you mentioned sort of using computers and to sort of do some teaching, this kind of moves away from the addiction piece a bit, but I noticed a reference in one of these studies to another study that you were involved in, where you've done some work using computers to support folks with HIV.
Mm-hmm.
What were you doing there?
Yeah, so there was another large clinical trial at the time that I was a postdoc in Ken's lab, in Dr. Silverman's lab, where we were evaluating the effectiveness of incentives for viral suppression for individuals with HIV who maintained high viral loads. So there's a lot of background there that I can get into. HIV is treatable now with antiretroviral therapy. Antiretroviral therapy involves taking a bunch of pills, but if those pills are taken every day for the rest of the person's life and they maintain perfect adherence or close to perfect adherence to that pill-taking regimen, then their viral loads can reduce to a point of being undetectable and can stay that way for the rest of their lives. They can live HIV-free for the rest of their lives and, not develop AIDS and have that shortened lifespan and other devastating health consequences that happen with the course of that disease. But sometimes people don't take their medication,
right?
Or they don't take it every day. And what can happen when people don't take that antiretroviral therapy every day is that they develop resistance to the effects of the antiretroviral therapy. And so it's critical for people to adhere to that treatment regimen as close to perfectly as possible for the rest of their lives, because there are only a few different types of ART, and if people exhaust all of their options there, then they're not going to be able to have those great outcomes from ART. So the trial was evaluating a very high magnitude of financial incentive money for maintaining undetectable viral loads, or at least for viral loads to decrease initially, and for those viral loads to stay undetectable over the course of a year. And it was really effective. So, I mean, this intervention probably saved lives.
Yeah. Amazing.
The incentive group maintained undetectable viral loads. We didn't even reinforce pill taking. They knew that they were supposed to take their pills. They knew they were supposed to take it every day. But what was reinforced is they provided blood samples, and those blood samples were tested for the presence of HIV RNA. And Dr. Silverman collaborated with Robert Silicano, a HIV researcher who understands, exactly how the viral loads decrease with the medication, and found the exact way to reinforce decreases and then maintenance of undetectable viral loads. And it's such a simple and incredibly effective intervention. I don't want to give an exactness, some 80% or more of participants in the incentive group maintained undetectable viral loads.
That's amazing.
It was an amazing study. And my involvement in the study was to look at how we can improve knowledge about HIV and ART and the antiretroviral therapy in individuals when they signed on to the study. So we evaluated in an education program that was based on the CDC educational materials out there about HIV and ART. and individuals had generally a very low knowledge of HIV and ART initially. We presented in a multiple probe design, 3 different modules that taught them about different components of the disease and its treatment, and then probed their knowledge 4 different times, once before any of the modules, once after the first module, once after the second, and then once after the third and final module. And it looks a lot like a multiple baseline design because it is a variation of the multiple baseline design. Sure. But what we found was we use actually fluency-based training in our modules where participants were given the information, presented with the information. They were tested in a SASMEDS kind of way. Yep. On that information, and then they took a cumulative test after that. And in the cumulative test, their knowledge increased significantly after each module for that module that they were tested on, and maintained for modules that they were tested on previously, and did not increase for modules that they were not trained on.
Really cool.
It was a really cool study. It shows the effectiveness of these applied behavior analytic tools that we have in training people on anything, really. We have such, I was trained when I was doing my postdoc at Behavioral Pharmacology Research Unit. I also got the real privilege of being trained by some of the pioneers in the field of contingency management, Dr. Maxine Stitzer, Dr. George Bigelow. And Dr. George Bigelow, I'll never forget one of the presentations he gave about contingency management, where he talked about this behavioral treatment is a generalist treatment. It's based on treatments that are broadly applicable to so many different behaviors. Whereas pharmacology, which is, I don't know, by the general public may be held in higher esteem, it's more medicalized, and, it's associated with health more than contingency management would be in the general population, is a specific treatment. It treats a specific type of substance use disorder. Methadone's not going to work for someone with cocaine use disorder. Buprenorphine's not going to work for someone with methamphetamine problems. They target specific receptor systems and specific processes. I mean, naltrexone is a great drug because it affects. It has been shown effective for individuals with alcohol use disorder and opioid use disorder and some other problems. But, it's still a specific treatment. But this tool that we have in contingency management is that it can be applied to any substance use disorder. And, looping back to our discussion on behavioral addictions, it could be a great intervention to reduce people's smartphone use, to reduce compulsive overeating, to reduce any distress caused by certain inappropriate sexual behaviors. And the same goes for, all of our applied behavior analytic technology. Our education and training programs can be applied to a variety of different populations to treat a variety, or to help build skills in a variety of different target behaviors, including, teaching kids academic skills and school sight words and all that good stuff, but also teaching adults how to use a keypad and type on a computer, or teaching individuals with HIV about their disease and how it can be treated. And so I just love applied behavior analysis and its broad application. And we can be, I encourage whoever's out there doing ABA to push those boundaries within your scope of competence, of course, but to push those boundaries in testing the effectiveness of whatever it is you're competent in.
The third secret word is fluency. Well, and something I also like, and just is sort of how you're kind of combining, different realms of ABA, particularly precision teaching. I mean, precision teaching is something that, lots of evidence, brilliant way of, brilliant measurement systems and so many good things around PT. And yet we don't see a lot of programs sort of in the ABA realm that take advantage of that. There's often, PT is often sitting on its sort of its own sort of island, and folks just aren't coming to access it, even though they provide a lot of pieces that can be really helpful in other areas. So to see that you're using contingency management, you're using the precision teaching, you're using the fluency stuff, and really kind of bringing that all together in an area that's completely outside of what folks would normally think to apply this technology to, is just awesome, and is going to really, I think, get a lot of people excited.
Yeah, for sure. I'm standing on the shoulders of giants with that one, but yeah, I won't take credit. Dr. Silverman has developed a lot of the models of integrating all of those treatments in a very creative way, and continues to do so. Yeah. And so it was great to have the opportunity to work with him as a mentor.
Totally.
And to think about behavior analysis in this very creative way.
I wanted to just, in sort of our last bit of time, well, all this is just amazing and inspiring and wonderful. It also takes, a lot of work to kind of build one of these programs, and
absolutely,
and kind of put all these systems into place. And we could certainly talk about what that takes at another time. But I know there's going to be listeners out there that are maybe working in a maybe a consulting firm on their own, and I think of it from sort of personal experience. At the company I work at, we get a lot of referrals that are folks that first off maybe don't even know what ABA or is or anything, and they're just sort of it's sort of the last thing on the list of things sort of a government program can offer is, well, let's try the behavior consultants and see what they can do. And sometimes we do get folks that are that are dealing with addictions, and often we don't even know what to do there. Once with that sort of piece, I mean, we can help with sort of other areas, but when it comes to actually kind of working with drug addiction kind of one-on-one, as a behavior analyst, are there things out there we can do as individuals to help folks beyond sort of developing a whole sort of county-wide or province-wide or whatever program to sort of address the needs of a ton of people and get a grant and so on and so forth?
Yes, and I wish I could solve that problem in a brief, or describe the solution to that problem in a brief statement. But I think one thing I want to emphasize is to just to do your research on understanding addiction. I think behavior analysts have an understanding that problem behaviors are learned, and that we're compelled to act in certain ways based on the selection of behaviors by their consequences. And it's really easy to see an individual with disabilities, an individual with autism, as suffering, or I don't want to say suffering, as experiencing these target behaviors, these problem behaviors outside of their control. But behavior analysts still hold stigma toward individuals with addiction,
yes,
as experiencing their problem behaviors as something that they chose to do,
yes,
declarative, that they can declare as a conscious choice.
Yes.
And so just so first, applying our understanding of human behavior to individuals with addiction, to get a more compassionate, to get a more compassionate understanding of addiction, will make us want to help a little bit more and advocate a little bit more for this population. And then understanding, okay, so what resources are there in my community that I can refer them to? There may not be widespread application of contingency management, but there might be places that use that a scientific understanding of addiction to treat it. And so coming up with a list, when I moved, so I'm not at Hopkins anymore. I transitioned from my postdoctoral position to a position as a faculty member at California State University, Stanislaus. I've been here for a few years now, and the first thing I did was I looked around for practitioners and individuals who are doing harm reduction work. There's a lot of really good, at least in California, where I'm fortunate to be situated in a place where there is a lot of really good work being done to reduce overdoses through community training using drugs like naloxone, which are pretty much harmless and easy to deliver when you see an individual overdosing from opioids. And so where are the programs that are training the community members on that? And can I get training? And I keep naloxone in my home and in my office.
So do I.
So looking for those compassionate approaches, individuals who are treating substance use disorder using evidence-based scientific approaches, usually county mental health programs or our government-sponsored mental health and behavioral health programs exist where we can make referrals. Knowing what those harm reduction programs are and whether we can refer people to them is also really important. And then understanding, okay, so what is my local government doing to support a scientific approach to treating addiction? So I got involved with some community organizations through the county and through the city to find out what individuals in government are doing. I found out some pretty cool things about California. There's the Mental Health Services Act, MHSA, that puts a tax on earners at the highest tax bracket. Like it's a 1% tax, so they're not missing it. To support programs that treat individuals who are treatment resistant, who have been through the system over and over again and are not able to get out of their circumstances. And some of the programs deemed as full service partnerships in my county are using models of assertive community treatment. They call it ACT, but it's not the same as ACT. Right. Except as a commitment therapy. But assertive community treatment is an approach where individuals are employed as outreach agents. They go out into the community, they find people where they're at, they give them, they use incentive programs and take people to the grocery store, take them to get a burger, and help them stay engaged with the treatment system so that when they are ready to do something to enter into addiction treatment, they know who to go to, or they know that someone's going to be coming by on Tuesday to give them a gift card. So assertive community treatment. Find out if that's happening in your community. See if you can get involved and, or at least, get some contacts in that space. Know who the outreach coordinators are, and maybe they can help with people you run into in practice.
And I suppose there's probably things, because obviously we're not, we don't have the competency to tackle this on our own. This is totally a collaborative process, a wraparound process, particularly with some of the medical needs and whatnot. And so I would imagine maybe some of our work might just be around sort of motivating individuals to access the programs. So and that might be things maybe through ACT, or I don't know. There's other ways we can sort of help folks doing that.
Yes, yeah. So, know where to refer people, but also I think one treatment that has been shown to be really effective with individuals with addiction who are ambivalent about making a change is motivational interviewing and motivational enhancement therapy. And behavior analysts can get some training in the core processes of motivational interviewing. And I feel like that can help us to make effective referrals, but also can help us to build really great rapport with our clients and stakeholders and third parties with whom we work in practice. Motivational interviewing basically just talks about how to develop good counseling skills. asking people open-ended questions, expressing empathy and active listening through using reflections when people are talking, reflecting back what the person is saying to you. So they can hear what they said more objectively, using things like affirmations, which, are descriptive praise statements, but using things like affirmations where you're calling upon the strengths of the individual who you're talking to help build them up, and helping them to see what they have said over the course of the conversation with you, using summaries, which is just a collection of reflections, where you can that serve a really good function to transition someone to talk about what you want them to talk about, or what you think would move the conversation forward, not in a directive way, but in an empathetic way. So motivational interviewing is a great has a great cluster of skills that behavior analysts are well suited to learn and implement and practice, no matter who they're talking to, whether they're making a referral to someone, or helping someone work through their ambivalence about their substance use disorder, or just connecting with our clients and stakeholders.
Yes. Yeah, it seems like like everything you're saying just seems like a big piece that's kind of missing, I think, from behavior analytic kind of training programs is sort of these counseling skills. There are some folks out there that end up becoming counselors and combining that with their BCBA or whatnot. But it's so surprising to me that we're not taught those skills when 90% of our job is dealing directly with people and trying to get them into sort of do it. Like I can see this being a really powerful tool, in terms of sort of parent training and kind of getting parent buy-in and whatnot, especially for folks that, like the ones I told you we were supporting, where they don't even know who we are and what we do. So that makes a lot of sense. Really cool. Just to kind of wrap things up, I'm just wondering, you mentioned, do your research. And so what resources are there out there for folks that are maybe just starting to want to learn more about addictions and learn more about kind of this kind of work? Are there like interest groups? Are there conferences or things like I know there's sort of obviously the ABA International and whatnot, and you might catch the odd thing here and there, but what are some really good resources for new behavior analysts, or not behavior analysts, that are kind of new to this realm?
Yeah, there are a number of researchers in behavior analysis who are publishing in behavior analytic journals like JABA, Journal of Applied Behavior Analysis, like Behavior Analysis in Practice, the Behavior Analyst, who are publishing on addiction research, on contingency management. So type in contingency management in a keyword search for those journals, and there's been in Behavior Analysis in Practice, I believe, recently there's been some articles about getting involved in addiction research, or maybe in Java. Oh, I can give you some of those resources so you can link them.
Perfect. Amazing.
And so there's great review papers, editorial papers, and research papers published in behavior analytic journals in addiction. So read about them, and in there are chapters in our behavior analytic textbooks on addiction treatment as well. Or Dr. Silverman and Holton and I and some colleagues recently published a chapter in the new Handbook of Applied Behavior Analysis on abstinence, behavior analysis and treatment of drug addiction.
Cool.
And then there are conference groups and special interest groups and whole conferences, actually. So if you know about the Association for Behavior Analysis International, there's an addiction special interest group, or SIG.
Okay.
I think actually it's going to date the podcast, but I think Dr. Holton is running that special interest group right now.
Very good.
Yeah. And ABAI just recently started a whole addiction conference.
Wow.
So that is another great resource out there. These conferences are a great way to get a sense of what is the cutting edge research that's happening right now that, is delayed in the publication process, but what's going on. And then I think that's all I had to say about that.
Yeah,
So,
no, that's pretty
research,
good.
special
That's
interest
pretty good.
groups,
Yeah.
conferences. And I encourage people to look at other journals that are publishing work on addiction, like drug and alcohol dependence or addiction, Journal of Substance Abuse Treatment. And there's behavior analytic work often being published in these journals, just not under the, keyword of applied behavior analysis.
That's a wealth of resources. A whole conference, though. That's definitely something I know I'm going to be looking up, and I'm sure others will. Is that an annual thing, or is that just have they had one yet? Or
yes, they have had the addiction conference. I'm not sure if it's annual or every other year. A lot of things have been stalled by the pandemic.
Of course. Wow, really cool, really cool. I had no idea how much is being done in this area. I definitely had a lot of misconceptions and misinformation. And I think others will have too, particularly around contingency management. I had no idea that it's been around for so long and had so much support behind it. And the idea, and again, the insurance company thing is just amazing. Really neat. So much really good stuff here. I think folks are gonna get a lot out of this. I know I have. Thanks again, Shrinidhi, for being on here. Really cool, really fun conversation.
Yeah, it's great to talk with you.
Awesome.